Okay, so I'm just gonna go ahead and share my screen. And again, thanks to all the learners for joining us today. And special thanks to Taryn for submitting a case that we're gonna discuss. So we've now come to the fifth module in our 5-part series. And today what we're going to really focus on is additional populations at risk for hepatitis B and how to optimize management for those populations. So let's start with our case that we've been slowly building on over the last several weeks. So it's a 28-year-old woman who's now pregnant. She's 32 weeks. She was born in the United States. Her parents emigrated from Taiwan 2 years before she was born here. The patient was screened for hepatitis B as part of routine prenatal screening. Oh, sorry, I just realized I'm not in presenter mode. Let me just, there we go. Surface antigen positive, and she's core antibody positive, so she's got active infection with Hep B. It doesn't look like it's acute infection because the IgM core antibodies negative. She's e antigen positive, which a lot of our patients who are younger and who this might be transmitted mother to child are often at this age. And she's got a very high viral load. Her Hep B viral load is over 1 million, and her ALT is normal at 18. So now what? So I'm going to kind of pause here, and we're going to come back to this case towards the end of the talk. So now our patient is pregnant. So let's start by talking about Hep B and pregnancy. And we know that pregnancy is a very immune kind of forgiving state in a lot of ways, in that the immune system gets modified in order for a woman's body to be able to tolerate the fetus and prevent, any issues around fetal rejection. Our body's always kind of trying to sense things that are foreign, not of its own, and so the immune system gets altered during pregnancy. Immune priming is known to occur via macrophage activation of CD4 and CD8 T cells. And CXCL3 expression in liver macrophages is ineffective at birth and becomes competent as one becomes older. And this could be the potential mechanism for why we see that inverse relationship that's very much dependent on the age at which you acquire the infection, really translating into the risk of chronic infection. So what I mean by that is that when you acquire this before you have liver macrophages that are more effective at being able to clear things like a hepatic virus, you're more susceptible to go on to develop chronic infection, which is what we unfortunately see very commonly with Hep B in terms of worldwide risks of transmission. So mother to child transmission still remains the, accounts for probably 50% or more of transmission of Hep B cases worldwide. This is certainly more common in geographic regions with very high prevalence, including East Asia, as well as probably sub-Saharan Africa, although there's probably more early childhood transmission in some of the West African and sub-Saharan African nations. So vertical transmission can occur via germ cells, transplacental or intrauterine transmission, or most commonly perinatal at the time of delivery. And so we know that this still represents kind of a big mode of transmission, and so it's really important for us to be vigilant and be discussing how to test every pregnant woman for Hep B surface antigen as early as possible to understand what their status is, and then be able to really manage patients who you identify as being infected. So if somebody's surface antigen test during pregnancy is positive, so all women in this country are recommended, if they're pregnant, as part of their prenatal care, to have surface antigen testing. This is most commonly done by the OBGYN and family medicine providers who are on the front line of managing these patients. If you are infected and surface antigen positive, we need to assess your liver function and liver fibrosis as early as possible using labs, ultrasound, and non-invasive markers of fibrosis. We can check the labs that we check very commonly for anybody who's got Hep B infection, including your ALT level, your E antigen status, and your Hep B DNA. These are really recommended to be checked closer to your third trimester to determine the need for antiviral therapy. And then really close monitoring of your serum ALT and Hep B DNA is needed throughout your third trimester up to 6 months postpartum. So let's talk a little bit about obstetric interventions and the risk of mother-to-child transmission. So what we know is that the risk of mother-to-child transmission with prenatal procedures is unclear. Some of the earlier studies thought that procedures such as amniocentesis, chorionic villus sampling all increased your risk definitively, but the more recent studies look like that with procedures such as amniocentesis, there's a 50% risk of mother-to-child transmission rate in mothers, but it's really in mothers whose Hep B DNA is very elevated, more than 7 logs per copies per ml. So with some additional studies, they've looked at what are the true risk factors for moms who are infected with these procedures. So it's not just all women across the board with these procedures, it's really women with high viral loads, which again, a lot of our young patients, particularly young patients who are foreign-born, where they have had this virus, for a shorter period of time, are typically end up in this category. And so the recommendation by the OB societies as well as the liver societies here nationally is that invasive procedures should be performed when medically indicated. And so there is not a clear contraindication to doing tests like amniocentesis, and other invasive testing if medically otherwise indicated. However, we should counsel those women who have very high Hep B viral loads that there is an increased potential risk of Hep B transmission with procedures. Now, the data on benefit of C-section is also conflicting. Hep B infection status should not influence the mode of delivery. So we don't necessarily say women with Hep B should all go for a vaginal or cesarean section. It really should be guided by the obstetric indication for the mode of delivery. And we do know that Hep B DNA can be found in actual vaginal secretions, more than 50% of women who are infected. But we typically say we're somewhat agnostic in terms of the recommendation for the mode of delivery when you're from the Hep B standpoint. So there are some ways that we can try to minimize or prevent mother-to-child transmission of this virus. So we do this through what we call immunoprophylaxis. Immunoprophylaxis includes administration of Hep B immunoglobulin plus Hep B vaccine to the infant less than 12 hours after birth. And this offers the greatest protection to infants. And it's this coupled with consideration for antiviral therapy during the third trimester of the mom are the two ways we can really maximize risk reduction strategies to babies. And it's really important that additional doses in 1 and 6 months of Hep B immunoglobulin and Hep B vaccine are required for lifelong immunity. Now, the women who are at highest risk to transmit this to their child are E antigen positive women. And without vaccination for Hep B, we know that more than 90% of infected moms who are E antigen positive have a risk of transmitting this to the infant. If we implement Hep B vaccination and immunoglobulin within the first 12 hours of birth in E antigen positive women, we reduce that risk to 10 to 15%. So it doesn't go to 0. 10 to 15% is still a pretty sizable risk, but it reduces it quite dramatically in terms of preventing a mother-to-child transmission in that infant. E antigen positive women, E antigen negative women, have a much lower risk of transmitting this, but it's not 0. So even without vaccination or immunoglobulin, you have a less than 5% risk of transmitting this to the child at the time of birth. And with vaccination and immunoglobulin administration within the first 12 hours of birth, you can reduce that risk to less than 1%. So really, really important ways to try to immunoprophylax and reduce transmission risk. Now, we do know that, again, there are certain features of mom's Hep B status and infection that put them at higher risk for transmission. And certainly the Hep B DNA viral load being more than 8 log copies per ml is associated with the highest rate of perinatal transmission, 9 to 14.6%. And that transmission rates can be 3.2 to 6.7%, even when the Hep B DNA is in a lower range of 6 to 8 log copies per ml. Now, lamivudine, talbivudine, and tenofovir are considered safe during pregnancy. TAF has not been as well studied, and therefore the strength of data is not there in TAF, therefore is not recommended for pregnant women in terms of antiviral treatment for the mom. Tenofovir is the preferred drug by AASLD and other professional societies to minimize the risk of emergence of viral resistance, which you can sometimes obviously see with lamivudine if treatment is continued beyond pregnancy. So tenofovir, as I mentioned, is preferred for mothers whose Hep B DNA is greater than 200,000 IUs. And now we've switched from copies to IUs. Remember that the conversion factor for IUs to copies is 1 IUs to 5.4 copies. So so you have to do that calculation, and it's important to kind of be comfortable with IUs and copies per ml and understand what the magnitude of difference is there. Now, tenofovir is effective even if there's resistance to lamivudine or talbivudine, and so it's just easier to think about kind of one treatment that's going to really fit all moms, and therefore tenofovir has been the medicine that's had the greatest safety data and also has the lowest resistance data, and therefore that's why it's recommended. We know that fetal exposure to drugs generally in the first trimester can theoretically cause mitochondrial toxicity and potential risk for fetal organogenesis. So the ideal timing of antiviral therapy is between gestational weeks 30 and 32, so really that third trimester timeframe. And therefore, you should be checking the Hep B DNA viral load, the E antigen status, as well as the ALT levels, all in that second trimester if possible, but then closer to the third trimester to try to determine whether or not a woman is going to be recommended for antiviral therapy. Now, the one exception is that mothers with cirrhosis, and we do have cirrhotic women who become pregnant who have Hep B, they should initiate antiviral therapy as early as possible in their pregnancies. We don't wait to 30 to 32 weeks. The risk of flares, which can happen during pregnancy, so flares of Hep B infection, can result in decompensated liver disease and poor maternal fetal outcomes. So any cirrhotic woman who's pregnant with Hep B, you initiate antiviral therapy with tenofovir if they're not already on it to try to protect mom and baby and have better outcomes. Now, after delivery, it's important that we have management plan for Hep B infected women. And we know that the rapid hormone fluctuations that happen postpartum can really drive immunological changes that can result in increased risk of hepatitis B flares with, sometimes we see very dramatic elevation in the ALT and liver enzyme tests and the Hep B DNA levels postpartum. And breastfeeding is not contraindicated. It does not increase the risk of Hep B transmission. The only caveat to that is that if you have overt bleeding from mastitis or bloody discharge from in your breast milk during the time of breastfeeding, it's recommended to not be breastfeeding in those circumstances. But across the board, we don't consider it a contraindication by itself to breastfeeding. Mothers on treatment can choose not to breastfeed as medication can be secreted in small doses in milk. There is a thinking that sometimes antiviral therapy in these small doses is not an overt contraindication, but it's really important to counsel women and to really have an informed discussion that's driven by kind of the patient's comfort level based on the information that you present. Hep B infected pregnant women who are not on antiviral therapy, as well as those who stop antiviral treatment at or early after delivery, should be monitored closely for up to 6 months after delivery for hepatitis flares. So the timing for when we recommend to stop antiviral therapy is usually at the time of delivery or within 1 month postpartum. And the reason for that is that the studies looking at continuing antiviral therapy don't result in a decreased risk of flares or other issues to the mom or baby. So there's really no benefit in that period to continue it beyond a month postpartum. But whenever you discontinue antiviral therapy in somebody who's infected with Hep B, it's really important that we monitor these patients for flares. So we typically, we'll do at a minimum blood tests, monthly during this time period and for up to 6 months. And then it's really important that any mom who has hepatitis B is followed up long-term to have an assessment about whether or not they need antiviral therapy long-term. So this kind of gives you a nice schematic in terms of how you can think about preventing perinatal Hep B transmission. And this is a schematic that has been developed by the CDC. It's available on their website. So we've taken it from them and given them the credit along with the URL at the bottom here. So when a woman presents for delivery, you want to know what is their Hep B surface antigen status, and sometimes we don't always know that. So if the status is known, so we have the test result available and we know that the woman is infected, it's important to notify the whole labor and delivery team as well as the pediatric teams to make sure that the nursery can make sure that they can administer Hep B vaccine and Hep B immunoglobulin within 12 hours of birth. So timing really is important. The studies have shown that you reduce the transmission the most with this optimal timing. So it's not before discharge from the hospital, it's really within 12 hours of birth for infants born to women who are infected. And then you want to administer Hep B vaccine and the immunoglobulin in separate limbs in case there is like a site reaction. You can monitor that. And it's important, this is also a public health notifiable condition. The CDC as well as your local health departments collect this data to kind of really track whether or not babies are getting appropriate immunoprophylaxis and followed appropriately, both baby and mom. Now, if the baby is less than 2,000 grams, you administer another dose of Hep B vaccine 1 month after birth, and the birth dose does not count towards the vaccine series. If the mom is not infected with Hep B, but they have risk factors present. So they have had, at the time of delivery, they're reporting to you, they've had multiple sexual partners within the last 6 months. They have any history of an STI within the last 6 months. They report injection drug use, have a surface antigen positive or Hep B infected partner, or any clinical picture that fits with hepatitis, like you have jaundice and you're checking liver tests. Those women need to be retested for Hep B surface antigen. And if they don't have any of those risk factors, they don't need to be retested because you already know their status and they're low risk. Again, based on the baby's weight, you still are going to, in this country, we implemented universal Hep B vaccine in 1991. And so they get their standard Hep B vaccine. And let's say you don't know the status of their Hep B surface antigen test before a woman presents for delivery. So then we do it based on the baby's weight. And if we don't know that mom's Hep B surface antigen status, then based on the baby's weight, if they are less than 2,000 grams, we go ahead and administer the first dose of Hep B vaccine and immunoglobulin within the first 12 hours of birth. And if the baby is not under this weight, you can just administer the first dose of the vaccine within 12 hours of birth and not give them the immunoglobulin. And then you still want to go on once to screen the mom. And once that test is available, you kind of follow the pathway here for either if they're infected to go ahead and administer another dose of the vaccine at 1 month, let the pediatric providers know to monitor the infants, and referring the women to the Hep B. There's a national CDC funded Hep B coordinator program. And then if in those women who have babies where the baby is not less than 2,000 grams and you've given them the first dose of the vaccine, and then you find out the women's Hep B surface antigen status comes back, and if they're positive, you go ahead and give them then the immunoglobulin as soon as possible, hopefully no later than 7 days after birth. And if they're negative, you go ahead and follow the recommended standard vaccine schedule for all babies. Okay. So this just kind of gives you another view of how to kind of put your algorithm for management of Hep B in pregnancy. So you start by testing all women as early as possible during pregnancy. For anybody who's surface antigen positive, you want to do some type of assessment around of stage and disease activity non-invasively. We don't do biopsies in pregnant women if we can avoid them. If they certainly have any markers by FIB4, OPRI score, of advanced fibrosis, or their ALT is greater than 2 times the upper limit of normal, you want to consider whether or not they're taking already antiviral therapy. If they are, then you want to continue tenofovir if that's the case. If they're not taking tenofovir, but taking another agent, and their Hep B DNA is detectable, you will continue. If the Hep B DNA is not detectable on telbuvudine or lamivudine, you'll continue that throughout pregnancy. If they're not on any antiviral therapy, you want to go ahead and initiate tenofovir therapy and continue that throughout pregnancy. And if they're taking some other agent, you want to think about switching them to tenofovir therapy, since that's, again, what we have the best safety data on, as well as the lowest risk of resistance. So that kind of covers broadly women who are pregnant who have Hep B and the need for screening for Hep B, and also how we reduce mother-to-child transmission, which worldwide remains a big mode of transmission for Hep B. Want to switch now kind of to another population of patients. You've heard probably about this condition of Hep B reactivation. Hep B reactivation is defined as a clinical syndrome characterized by a sudden increase in Hep B replication due to a loss in immune control. So the important things to realize here is that this can occur in patients who have Hep B who are surface antigen positive and core antibody positive, but it can also happen if you're surface antigen negative and you're just core antibody positive. So it really does not matter what the status of your surface antibody is. Essentially, being core antibody positive and or surface antigen positive puts you at risk for Hep B reactivation. And the reactivation can really present as a wide clinical spectrum, from silent elevation in liver tests to overt liver failure. I work at a liver transplant center, and every time I'm on service, and at least once a year, we have one patient who gets admitted with Hep B reactivation in the setting, most commonly of having received immunosuppressive drugs. One of the things that makes it challenging for us to study Hep B reactivation is that there's been a lack of standardized criteria for how we define reactivation. So we're going to talk about this a little bit, just what general things to look for. So the AASLD, our liver professional organization, has come up with criteria for how we define reactivation. But what you'll also see in the literature are, before these criteria were in place, or based on literature that comes from kind of across the globe, there are some generally accepted criteria that have been described in a lot of the studies that have been published. So let's start with the AASLD criteria. So a rise in Hep B DNA from baseline. Again, it's not really giving us clear cutoffs here. Is one criteria for Hep B reactivation. The other criteria could include reverse seroconversion. So this is where you're surface antigen negative and you become surface antigen positive for people who are just core antibody positive. Or the last criteria is after Hep B reactivation, you have hepatitis flare and ALT elevation. So the AASLD criteria don't really give us hard cutoffs of how much you have to have a rise in your Hep B DNA, how much of an ALT elevation. So they're somewhat loose. I have a feeling over time these criteria will get refined once we have more data in this area. Now, what you'll also see kind of across when you look at the literature and other studies is that some generally accepted criteria include a greater than or equal to 1 or 2 log increase in your Hep B DNA. So it's not just going from like 200,000 to 205,000. You want to see at least a log increase in your Hep B DNA. And then in Hep B DNA levels that are high, if the ALT also suddenly increases, that could be a sign that this is going along with a flare. De novo detection of Hep B DNA or e antigen. And then reverse Hep B surface antigen seroconversion. So that's where you go from surface antigen negative to surface antigen positive. And the ALT cutoffs that are used, so those are the virological criteria. For the ALT, greater than or equal to twofold increase above baseline, or if it could be as high as multiple times the upper limit of normal. The AST elevations are not always present in these patients. So the risk of reactivation really has to do with host factors, viral factors, as well as other factors, most commonly drugs, because we're talking about patients who are immunosuppressed being at highest risk. So we know that younger patients, men, and having an elevated ALT before initiation of any immunosuppression, that's what IS stands for, and other comorbid conditions put you at higher risk for Hep B reactivation. Hep B reactivation also can happen more commonly when you have a high Hep B DNA load at baseline, your surface antigen positive, your E antigen positive, and it also depends on the intensity and duration of the immunosuppression drugs you might receive. Now, there are a lot of different immunosuppressive therapies that are being used nowadays for a wide variety of diseases and disorders. The rituximab agents certainly have very high, highest risk of Hep B reactivation, but we can also see it even with high dose steroids and also very high risk with stem cell transplant. So when you think about kind of the various agents that you're using for immunosuppressive therapy, and you look at kind of the risk of reactivation, certainly the scenarios in which we have the highest risk of Hep B reactivation include stem cell and solid organ transplant. So for all of these patients, we're screening them for Hep B and antiviral prophylaxing them if they are core antibody positive and or surface antigen positive. The next class that has very high risk of reactivation include B-cell depleting agents. So rituximab is one that's used quite commonly for a number of conditions. Steroids also in high doses, not low dose steroids, but high dose steroids put us at risk for Hep B reactivation. And then less risk is seen certainly with agents such as azathioprine, 6-MP, and methotrexate, but have been reported much less commonly. So the AASLD screening recommendations for Hep B reactivation should be done in the setting of immunosuppressive or cytotoxic therapies. So all candidates for immunosuppressive, cytotoxic, immunomodulatory therapy should be tested at a minimum for surface antigen and core antibody before immunosuppression is started. The presence of surface antibody does not prevent Hep B reactivation. I think that's a really important take-home point. So it's really important that you screen them for surface antigen and core antibody, and we don't really care in this scenario so much about being the surface antibody status. Hep B reactivation is more common in persons who are surface antigen and core antibody positive, and it's been reported to be as high with anti-cancer therapies as 41 to 53% in people who are surface antigen and core antibody positive, but they also is a substantial risk in those who are surface antigen negative and core antibody positive, 8 to 80%. And then Hep B reactivation has also been looked at in the literature in terms of anti-rheumatic therapies, where we see a lot of these immune modulatory therapies, and in, again, higher rates of reactivation in those who are surface antigen and core antibody positive, upwards of 12%, but even in those who are just core antibody positive, it's 1.7%, the risk of reactivation. And then finally, the other big point here is that Hep B testing rates are incredibly low, even in cancer patients. So patients who we know we're going to be doing potentially chemotherapy on, we know that testing rates are about 50% or less. Unfortunately, one of the big things that has changed provider practices is having an individual bad outcome with the patient, where patients were not appropriately screened and then developed reactivation. And as I said, I see at least one case of fulminant hepatic failure in the setting of Hep B reactivation a year, most commonly in the setting of cancer therapy. So all patients who are surface antigen positive and core antibody positive should initiate Hep B prophylaxis with antiviral therapy before immunosuppressive or cytotoxic therapies are initiated. So At the very least, it should be done simultaneously, but ideally before. But sometimes, again, if the competing issue for why you need to start the immunosuppressive or cytotoxic therapy is very pressing, it's okay to start those two things concomitantly. And the recommendation is to continue Hep B prophylaxis during immunosuppressive therapy for up to 6 months after completion of therapy. And in those who are receiving anti-CD20 therapies, including the rituximab patients, therapy should be prolonged for at least 12 months or longer. And I have seen cases of fulminant hepatic failure where antiviral therapy was stopped at 6 months in these patients who receive anti-CD20 therapies. So recommended prophylaxis is with entecavir, tenofovir, or tenofovir alafenamide, so TAF. These have, again, higher potency, they work really quickly, and they have higher resistance to resistance barriers. And in surface antigen negative and core antibody patients, core antibody positive patients, these patients can be carefully monitored with serial ALT and Hep B DNA and surface antigen periodically with the intent for what we call on-demand therapy. And the exception to this is those receiving those anti-CD20 antibody therapies, namely rituximab, or anybody undergoing stem cell therapy. And for those patients, we would go ahead and recommend antiviral prophylaxis with entecavir, tenofovir, or TAF. And for patients being monitored without prophylaxis, so they're not on one of these anti-CD20 therapeutic agents or receiving a stem cell or solid organ transplant, the monitoring should be done with DNA levels at least every 1 to 3 months. And patients should be monitored for up to 12 months after you stop any antiviral therapy to watch for flares. So that's kind of an overview of the concept of Hep B reactivation. And then I think one of the last topics we wanted to cover was Delta infection. So we know that Delta virus is a defective RNA virus that requires the presence of Hep B virus to replicate. So the incubation period is anywhere from 5 days to close to 2 months. And the types of infection really fall into 2 different patterns or categories. The first is superinfection, where we have a chronic Hep B infected patient who then develops acute Delta virus. This has a worse prognosis, and 80% of these patients go on to develop chronic infection and more severe disease. So again, these patients already are chronically infected. They then get Delta virus infection, so then they have really 2 viruses that are accelerating the course of the disease course, so patients can develop more fibrosis in a shorter period of time. Sometimes we see actually cirrhosis in a very short period of time, and they can have a worse prognosis with more severe disease. So that's one scenario. The second scenario is where you acquire both infections at the same time. Certainly we're seeing actually more and more of this scenario because risk factors include injection drug use and sexual transmission. And we know that, certainly one of the unintended consequences that we've seen with the opioid epidemic has been an increase in the number of Hep B infections. And so we're also seeing some more Delta infection in this context. This scenario where you get both viruses together is typically self-limiting because, again, this is going to more commonly happen in adults. And in adults, you typically have an immune system that for 85% of the time can clear the Hep B virus on its own. And once you clear the Hep B virus, you clear the Delta virus at the same time. So that's why getting both of these viruses together is actually a better scenario to have because it's typically self-limiting. The vast majority of patients will go on to clear it. Less than 5% of patients, again, will have chronic infection with both of these agents because they don't effectively clear the Hep B. And then the one thing, this is more kind of a board review question, but the classic scenario would be where you get a patient who comes in kind of with a viral prodrome, the ALT goes up and then it comes down, but then it goes back up again. And that kind of is a characteristic pattern that we see more commonly with this co-infection with B and Delta virus. The diagnosis is done through a Delta antibody. You can actually check an IgM and an RNA DNA level. an RNA viral load level for your Delta virus. Sometimes we consider liver biopsies in patients who have Hep B and Delta who look like they have more advanced fibrosis to have a very clear understanding of what's going on. And again, in these patients, when they're being presenting for the first time, especially the co-infected patients and super-infected patients, they can be kind of asymptomatic. They can present as more severe chronic hepatitis, but they can also present as kind of fulminant hepatic failure, because anybody who's got Hep B, even chronically, who then you superimpose an acute additional viral illness that predominantly affects the liver, they can certainly present as a fulminant hepatic failure picture. The treatment, the standard of care treatment is pegylated interferon for 12 to 18 months. That being said, there was more recent data presented at the annual liver meeting in Boston a few weeks ago, where they're now looking at ribavirin-based treatments in addition to try to shorten the time period as well as improve the cure rate with Delta virus. So I think with that, I wanted to pause here and open it up to questions. And I also wanted to then go back to our 28-year-old pregnant woman case, is 32 weeks with chronic infection, and also talk about Taryn's case. So I'll go ahead here and just take a quick pause to see if anybody has any questions. And feel free to use the chat function or take yourself off mute. And while we're doing that, I'm going to kind of go to the top of my slides here to the case, and then we'll get to Taryn's case after that.
Hi, this is Katie. I just had a question about monitoring for Hep B reactivation during Hep C treatment.
Yes.
If someone only has core antibody.
Yeah, so the specific scenario Katie's talking about is we now recommend anybody who's infected with Hep C to also be screened for Hep B before you start antiviral treatment for Hep C. And the reason for that is we've seen several cases now of Hep B reactivation in the context of treating somebody's Hep C. So it's really important to screen everybody with Hep C for not just surface antigen, but core antibody as well, because anybody who's core antibody positive is also at risk. We've actually seen people die in the context of Hep B reactivation when we're treating their Hep C because they were not adequately screened for Hep B. And we've even seen Hep B reactivation, although it's much lower risk, Katie, in those isolated core antibody positive patients. So it is recommended in anybody who is core antibody positive and or surface antigen positive, that we know your status before you start Hep C treatment, and that we think about antiviral prophylaxis. We've had patients die because of Hep B reactivation and trying to treat their Hep C. So the FDA has issued a warning. The AASLD and IDSA combined Hep C guidelines now say we should be screening and prophylaxing any patients, including those who are core antibody positive, because those patients are at lower risk than the surface antigen positive people, but are still at risk for reactivation. Does that answer your question, Katie? So I think,
yeah. It answer it, but I would still, we haven't been, I treat a lot of Hep C, but we have not been prophylaxing just core antibody. So I guess that's my question about that process, but I can talk to you offline or think about where am I in.
Yeah, and I can send you guys the link to the recommendation. So I think with the core antibodies, you certainly can do, again, on-demand monitoring. So, our patients with Hep C, the monitoring has become so limited, right, for 8 to 12 weeks of treatment, that you have to check the DNA level to know what's going on, and surface antigen. So you're either going to bring them back more frequently to do that monitoring, or you're going to temporarily put them on antiviral therapy. So I think there's a little bit of provider variance with that. So it really depends on what your practice is, how you want to monitor, how engaged your patients are going to be in monitoring for their Hep C treatment for the Hep B reactivation. So it's not always a one size fits all. It really depends on kind of what your comfort level is and how often you want to monitor patients. Yeah. Okay.
Great, thanks.
Yep. So we have this 28-year-old pregnant woman. She's 32 weeks gestational age. She was born in the United States. So we know that, obviously she's from, her parents are from a part of the world where Hep B has a very high prevalence. So we have no test to know how she got the virus or how long she's had it, but one could potentially, think about whether or not the woman herself got this from mother to child transmission. But she's screened nonetheless, so she's positive and she's pregnant, and she has a high Hep B DNA level, but a normal ALT. So what are some things that you would be thinking about at 32 weeks in terms of potentially managing this patient who has also a normal ALT? What are the things that put the infant at risk for mother to child transmission here? What are the things that are standing out to you?
Her high viral load. She's E antigen positive.
Right. So, and she's at 32 weeks. So this is
Correct.
definitely the right time to be being very vigilant and thinking about what are the risks and how am I going to mitigate or reduce these risks. So, so you have somebody who's E antigen positive. We know that increases your risk, and the Hep B DNA viral load is very high. So what things can we do to try to reduce the risk in the baby?
So I would give her TDF and then also start educating about postnatal care of baby with HBV and the vaccine. So, and then I usually give them a handout to take in with them. And I try and coordinate with their GYN provider if I can, just saying, hey, I know you guys know what
Right.
you're doing, but she is positive and has a high viral load. Sometimes when my patients have high viral loads like this, I find that starting them at 32 weeks isn't enough time to get their viral load down to less than 29. So sometimes I start these women during their second trimester just because I am concerned.
Yeah. So I usually recommend to check everything. I mean, usually by the time you're finding somebody surface antigen positive, the next test we do independent of time is the DNA test.
Yeah.
So I will then, depending on where I am with the pregnant woman, certainly be repeating that so that I have something kind of later in the second trimester to help me manage. But yeah, a lot of our patients don't get to undetectable in less than that 12-week kind of period. So, so starting it even as early as 28 weeks, some of the kind of other outside of professional society guidelines certainly have included that. Some of the European guidelines also include that. So, so late second trimester, early third trimester. They have looked at whether or not starting it even earlier, like early second trimester, leads to any benefit, and it doesn't seem like it does anything to reduce the rates of mother to child transmission further. Okay. So, so then the balance becomes trying to minimize any, toxicities, potential toxicities, even though these are very safe and pretty well tested drugs in terms of not having a lot of teratogenic effects to babies. So just optimal kind of timing. So yes. So, and then the other thing I would only say is that you want to make sure you've done a really good fibrosis assessment, right? So. Yeah. You want to know if this is a woman who is has more advanced fibrosis, has cirrhosis. We at the liver meeting, there was actually a couple of talks about how pregnancy and cirrhosis is actually happens a lot more than we think it should. And so it's something for us to be really aware about. So we need to do some type of fibrosis assessment. If a woman does have cirrhosis, you would be doing other things like an endoscopy during the second trimester to assess for varices. And you'd also want to make sure that the woman has HCC screening kind of, lifelong. So those are just some general things. Anything else anybody can think about as it relates to this case? Any questions?
I would also want to know the status of her partner too.
Yeah. And the reason for that is opportunity for engagement and care, or so just to screen.
Yeah.
We had such a marked increase in the number of sexually transmitted infections that we're seeing, right? The number of cases of syphilis, congenital syphilis, are it's kind of really mind-blowing, like what we're seeing. So so sexually transmitted infections are really on the rise. This is a sexually transmitted disease, so knowing the partner status, looking for opportunities for prevention or effective management if somebody's infected, their partner is important part of the care. So yeah, knowing the partner status is a really good point. Thank you. All right, so I think from there, I think what we'll do is we'll move to the case. And let me just, hold on, pull this up. Minimize this. So Taryn, you want to walk us through this case?
Yeah, sure. So this gentleman, I thought his case was kind of interesting.
Can everybody see my screen okay, or should I try to make it a little bigger? Is that better?
Yes, that's better.
Okay, let me try to even do it a little bit more if I can. Okay,
Great.
yep. Go ahead.
So this is kind of a middle-aged African-American male born here, slightly overweight with his BMI of 31.5. And he lives by himself. But essentially he came to me because he had this, as a new case of Hep B, he had this Hep B surface antigen positive on 2/21 of 19. And then I did some digging back, calling of labs to find records, and he was Hep B surface antigen negative back in 2015, 2017, and then again he was Hep B surface antigen negative on 10/25 of 19. So he kind of has this like blippy positive surface antigen, which was confirmed by like neutralization assay. So I didn't really think it was a false positive. And I checked it, E antigen was negative. I've never been able to catch any HBV DNA in him since I, started seeing him essentially back in like late February, early March. And then he has always been Hep B surface antibody negative, and he is core positive. So we do know he was exposed to the Hep B virus at some point, and I found that on 3/4 of 19 is when I checked that. Also, I guess of note, he also was co-infected with Hep C at one point, and that was treated in 2015. And so his Hep C viral load still remains undetectable.
Okay.
Yes.
So that's really helpful. Maybe we could pause there and then we can get into some of the labs below. So essentially you have a patient who's been, I guess one question that comes to my mind is, why has the patient been tested so frequently for Hep B? Have there been risk factors?
So not really risk factors at all, other than so not that he was disclosing, he is a prior drug user, but not using currently and hasn't for several years. But he works as a maintenance man in an apartment building kind of here in Baltimore City. And he says he's cleaning up like really gross stuff a lot of times. So, I was wondering about his exposure, and he was not provided with personal protective gear. He is now, because I said absolutely not. So he went back to his employer and demanded, gloves and such to clean up people's bodily fluids. So I wasn't sure if that was maybe his exposure risk, but, and I'm trying to think, I can't remember if I had an IgM or if they had one and it was negative. I think I wanted to check him for acute. He's not allowed to get labs drawn here, so I'm very limited in my ability to get labs because he has to go to an outside institution, and that's a little difficult sometimes with my population.
So this is really interesting. So you do have some pieces of data so it's kind of like a detective game. We're now trying to piece together.
Yeah.
How do we put all these labs together? And I would love for folks to chime in if they have thoughts. The things that kind of strike me here is that you have a number of surface antigen tests, and you have kind of one in between, that February 2019 where it was positive, but then you have a couple before that and one certainly after that were negative. You also have a surface antibody test from back in 2015 and then more recently that were negative. And you also then have one core antibody test, which again, this would kind of make sense in terms of, you know, what was checked. The core antibody then obviously was triggered to be checked because the surface antigen was positive. And then that test was positive. So I think to me, I would put this together as, yes, this person has had Hep B infection at some point. It would be nice if we had the liberty of another core antibody test before to kind of help us tell whether or not the February time point was the time at which he may have acquired. The good news is he's now surface antigen negative, and his Hep B DNA has remained negative at the time when it was checked, you know, after the February time point at least twice now. So I think you can be confident that the person doesn't have active infection at this time.
And also, his LFTs have been stone cold normal for me ever since I met him back in like early March.
Yeah. And so someone's bringing up a really good point. So the Hep C was treated in February. So, you know, Brianna Sprague, I think this is a really great point. Did the patient have mild reactivation in the context? Like, was this a core antibody positive person, right? Who was then treated for Hep C, had like a mild reactivation, was, you know, very transiently surface antigen positive. We didn't catch any of the liver tests.
He was treated in 2015 for Hep C.
2015. Sorry.
Yeah, sorry. And I checked again.
Yep.
Just to make sure there was no Hep C, because some of my patients are reinfection risks.
Right.
So I just checked to make sure that we still didn't have any HCV RNA when I saw him, just to try and clear some of the waters.
Got it. I just saw the 220. I think I misinterpreted February 21st, 2019 treated as it was 2015. Okay.
Yeah.
So I think that probably makes it less likely because the Hep B studies going back to 2015 looked negative. So I don't know if I would put that together. But that was a good thought because of the way we were reading it.
Yeah.
And then I guess, like, let's look at the rest of the labs here. The white count looks fine. The hemoglobin's low. So the platelets are normal, which, again, we sometimes use as just a rough surrogate for more advanced liver disease or portal hypertension. I don't know if this patient has some chronic known kidney disease. The glucose was 128, and the ALT is, 11, completely normal, and the Billy's normal. So, technically, if you're surface antigen negative, there really isn't recommendation, and it remains negative, right? Then there isn't really, the AASLD has a line now that they've added in their updated guidelines, which we can send to you guys, that they don't need long-term monitoring. The one thing for this patient, though, is that they are core antibody positive. I think it's real. So I think this is somebody who just needs to be aware that if they do have any other problems that would require immunosuppressive cytotoxic therapy, that they could be at risk for reactivation.
Yep.
4 months, right?
Yeah, and the guidelines are murky here about how long to monitor them. So I would just say if the surface antigen is documented negative for like a year, then there isn't any recommendation to do any longer term monitoring.
And would you check that like every 6 months?
So probably twice a year, just at 6 months and at 12 months.
Okay.
And then your other question was, is there transmission risk? So that's a really good question.
No.
So in somebody who's surface antigen negative, there is not transmission risk. And you've also been very confidently done your due diligence to look for the Hep B DNA level, and that's negative. So there's no transmission risk here. And then the question about vaccinating the patient is a really interesting one. So Katie, was it you who brought this question up earlier in one of the webinars or modules?
Sorry, it takes me a while to get off mute.
That's okay.
Yes, I did.
So you had brought up, like, if a patient with HIV, so I will also send you something in the guidelines. There's kind of, for certain risk groups, you can try the vaccination strategy to see if they develop the surface antibody and tell if that's a real, it's really to determine whether or not that's a real core antibody. I think in this case, we think this is a real core antibody based on the testing you've done. So I don't think that would be a strategy that's going to result in developing a surface antibody for this patient. So I wouldn't recommend it.
Go ahead.
Go ahead, Katie.
I was just gonna say, if the core antibody is real, always trust it as.
Yeah. Agreed. Totally agreed.
Yeah.
So I wouldn't recommend that strategy for this patient. Yeah.
Okay.
Very interesting case, but it is like a game of being a detective and putting it together.
Yeah. Yeah. And it's not very clear, you know, it's just, like you said, like Hep B never plays by the rules. So it's, you
It
know.
breaks all the rules. It just
Yeah.
doesn't follow any of the things like it does for like Hep C and other things. Are there any other questions or comments about this? I know we're at the top of the hour, but wanted to see if anybody had any thoughts or comments or questions. Okay, then I will, somebody asked, Brianna Sprague asked what type of drug use for the patient. I don't know if Taryn, you have that information.
I believe I can look back in my note. I mean, here in Baltimore, we like our IV heroin quite a bit. So usually it's some combination of heroin and, you know, cocaine or something, but I could look back. He hasn't used in, I think, like 12 years or something, a long time. So I just don't really, and he used to pay for sex, but does not anymore. That's the other risks that I forgot to put down there.
Okay.
But does not anymore. I'm trying to dig back. Sorry, I'm pulling up his chart to see. I think it was IV heroin back in the day is what he used, but has not in a long time and does not consume alcohol, all those things. He's trying to lead a different lifestyle.
Yeah.
And
I mean,
it's been doing really well.
I think occupational risk exposure certainly.
Yeah, that was my biggest concern for him based on his story of places that he's cleaning. So, and kind of, you know, urban environment. So.
I just say it's been really great and I really enjoyed getting to know all of you. You have my contact information. If I can be of any help, feel free to reach out at any time.
Thank you so much, Ponni.